times. And then the best result is taken. But the three efforts that you made, okay, must not vary by more than 5% from one another. Okay, so that would mean that the patient had consistent effort, okay, before you pick the best result. Okay? So that's how you're going to validate the result. Like now, I tell the patient, take a deep breath and blow it all the way out, and they did 7 liters. And then I said, okay, take a deep breath and blow it all the way out, and then the next time they did only did 2. And then the next time they did 20. So that's not consistent effort. They have to have consistent effort to validate the results. Okay? So reliability will be that the subsequent attempts must be within that 5%. Okay? Now, if they did it 3 times, how would you know which one is the best effort? They ask that a lot on the exam. Okay, out of the 3 efforts, which one is the best effort? So what you're going to do is you take the the FVC of each test and add it to the FEV1 of each test. Okay, whichever one is the highest value will be the best effort. Okay, that's how you're going to know which one is the best effort. Any questions about that? So you're going to have to add up the FVC to FEV1 of every test, every individual test, and then whichever one has the highest value will be your best effort. Any questions about that? So this is what it kind of looks like, okay? Now this is where the patient is exhaling out. They take a deep breath and then they blast the air out of their lungs, and then we keep on measuring here. So like right here, this is time here, horizontal axis, and this is your vital capacity volume. So right here, the patient started exhaling here. This is the first 1 second here. So in the first 1 second, they exhaled like 4.5 approximately. Okay? So if I want to find the flow rate, I'm going to divide 4.5 by 1 second. Okay? And that will give me 4.5 liters per second. Now remember flow, the standard measurement for flow is liters per minute. So if I get 4.5 liters per second, I multiply by 60, and then I convert it to liters per minute. So that's why I'm going to measure the flow rate. And then the patient continued to blast the air out. In 2 seconds, they got this amount of air out of their lungs, about 5.2 or so. In 3 seconds, they got this amount out. In 4 seconds, they got this amount out. Okay, so that's where we measure how much flow can you blow out of your lungs at a given time. Okay? Okay, so forced vital capacity should be equal to slow vital capacity under normal conditions. Because if your lungs are good, if nothing is wrong with your lungs, if you take a deep breath all the way and blast it out very fast, you're going to get the same amount of volume when you take a deep breath and blow it out slowly. As long as there's nothing wrong with your lungs, slow vital capacity must be equal to forced vital capacity in value. Okay, so normal slow vital capacity is 4.5 liters. Normal forced vital capacity is also 4.5. Okay? Forced vital capacity is an indicator of a restrictive disease, but not as good as low vital capacity. That is true. When your forced vital capacity is decreased, you may have a restrictive disease. Okay? But the problem is that it may also be normal in obstructive disease. It may be decreased in obstructive disease because of obstruction. Okay? So that's why we say that the slow vital capacity is the best indicator of restricted disease, because we'll give you time to blow it out gradually. And then if you do it gradually, you can't get enough, it means that you did not inhale enough to begin with. Okay, so slow vital capacity is the best indicator of restricted disease. Paul, go ahead.
Hey.
So, if the forced vital capacity is less than the slow vital capacity, it means you have obstruction. Because both of them are supposed to be equal under normal conditions. Okay? So that would mean that you have obstruction, obstructing the air from coming out from your lungs if you're doing it with speed. Okay, remember the emphasis on the forced vital capacity is speed. How much volume can you exhale out at a given period of time? Okay? All right, most individuals can exhale all their air in 2 seconds. Okay? If you cannot complete the forced vital capacity maneuver in 3 seconds, then you have obstruction. After 3 seconds, you still haven't exhaled all of your air out, then it means that you have obstruction. Okay? Forced vital capacity can be decreased in obstructive and restrictive diseases. Okay, now let me tell you why it will be decreased in obstructive disease. It will be due to obstruction. So remember I told you that compliance is down here, obstruction is up here. It's resistance, then compliance down here. So you have something here. Okay? So that's why the decrease in obstructive disease, because when you blast the air out, coming out from your lungs is going to meet the resistance. So you don't blow out enough air. Okay? It will be decreased in restrictive disease because we're down here, restriction is down here. Because your lung compliance is very, very low. Your lungs are very stiff. So you did not inhale enough to begin with. Now remember, our numbers are mainly greater than 80% of predicted will be normal. Okay, so let's say that a patient comes to the pulmonary lab and then I put their age, their height, their weight, their gender, all of that in the computer. Let's say the computer says, well, you're supposed to do 6 liters based on all the information that I put on there. And then we take the test, we put the patient to do the actual test. So because the patient's lungs are so restricted, they can't inhale enough volume in. Maybe they only inhale at 3 liters because they have stiff lungs. So you divide that out, that's only 50%. Okay, so that's why the forced vital capacity will be low. They did not inhale enough in, compared to what the computer said that they can do. Any questions about that? So, yeah, I've already explained that. So it's lung compliance. Restriction means low lung compliance. Okay, so now we have FEVT. Basically what that means is that how much volume can you exhale at different time intervals? At 1 second, at 2 seconds, at 3 seconds, and so on and so forth. How much volume can you exhale when you're doing your forced vital capacity? So that's how we come up with FEV 0.5. How much volume can you exhale out in 0.5 seconds when you're doing your forced vital capacity? FEV 1, how much volume can you exhale out in the first 1 second? And then we have 2 seconds, and then 3 seconds. Okay? So we'll go as far as 3 seconds, because after 3 seconds, if you can't exhale out your volume out, you got obstruction. So I always go to 3 seconds. But the most important of all the FTEs, FEVTs, is the FEV1. That's one that we pay attention to. How much volume can you exhale out in the first 1 second when you're doing your first vital capacity? Okay? It is a good indicator of obstructive disease, but not the best. Not the best, okay? Because the FEV1 can also be decreased in restrictive disease. We're going to talk about that. The FEV1 can also be decreased in a restrictive disease, okay? It can be decreased in both. So it's not always the best indicator for obstructive disease, but it's a good one, okay? All right, here's another example here of spirogram when they're doing the forced vital capacity. So the patient started off by breathing, taking normal breaths, breathing out, and then the technician says, take a deep breath all the way, blow it out. Keep on blowing, keep on blowing. Now you see the 1 second here. This is the 1 second mark here. So the patient exhaled about 2.8 liters. That's your FEV1, the first 1 second. And right here, okay, that's about what? 3 seconds or whatever. But now, this is how much they exhaled out. So that's the way we measure that. Okay? Now let's go to FEV1 now. So the FEV1 again is how much volume you exhaled out in the first 1 second when you're doing your first vital capacity. You took a deep breath and you blasted out into the spirometer. How much of it did you exhale in the first 1 second? Okay? Normal is 80% or better. So 80 to 100%. So what we're saying is that if you can exhale out or empty your lungs 80% or better in the first 1 second, then you have normal lung function. If you can take a deep breath and get out 80% or more of your lungs out in the first 1 second, you have normal function. Okay? FEV1 is decreased in obstructive disease. The reason again for that is because of obstruction. Remember, we talked about the obstructive diseases. We talked about cystic fibrosis. They make a lot of secretions in their airways. That will block the flow from coming out. We talked about asthma. They always have bronchospasms. Their airways will kind of like narrow. Okay? And then that impedes flow from coming out. We talked about chronic bronchitis. They have a lot of secretions. That blocks air from coming out. We talked about emphysema, where they lose elastic fibers. So they don't have the elastance to push the air out. So they do a lot of air traffic. And then we talked about bronchiectasis, where you have the dilation and damaging and rupturing of the bronchi. Okay? That would also cause air not to come out. Okay? So it will be decreased in all the obstructive diseases. And then it says that FEV1 may be proportionally low in restrictive disease, okay, compared to the predicted value of the FVC. And that is true. Now let's look at that. Now, my patient comes in, and I get their height, their weight, their gender, their race, and all of that inside the computer. And the computer said, well, okay, you're supposed to do 7 liters based on all of that information that we put in. And then I put the patient to the machine. I said, okay, I want you to do the test. Now remember, the patient is restricted already, meaning that their lung compliance is low. It can't expand and get more volume in. So when the patient does it, because they're so restricted, they will not inhale enough volume in. Let's say that the patient inhaled only 3 liters because they're very, very restricted. And then when they blow out, in the first 1 second, they only blew out 2 liters. So now you compare what the patient actually did to what the computer said that the patient could do. This is what you get. So it's low, FEV1. Okay? Any questions about that? That's why the FEV1 will be low. So it will be low in restricted disease because the patient will not inhale enough volume because they're so restricted. Okay? Compared to what the computer said that they can do. It will be decreasing obstructive disease because of the obstruction, obstructing air from coming out. Okay, so that's why we say that the FEV1 is a good indicator of obstructive disease, not the best, because it can also be decreasing in restrictive disease. Any questions about that? And so this is the ratio here. We call this FEV1 ratio, or FEV1 over FVC. What this here means is we're going to divide what you exhaled out in the first 1 second over what you exhaled out altogether. Your own vital, not predicted now, your own vital capacity plus your own FEV1. So that's why this is the best. Because now if you take somebody who is restrictive and you have them take a deep breath and then blow it out, they're going to blow out a volume in 1 second, but then when you compare it to what they inhaled in, you get a higher percentage, as opposed to comparing it to what the machine said that they could do. You all see the difference? We're comparing to what they actually did, not the predicted value. So that's why we say that this is the best value in our PFTs. Because if you're doing PFT interpretation, they give you the ratio, you're done. This never lies. Whether you're obstructive or restrictive, it's gonna know. Okay? So the ratio of what you exhaled out in the first 1 second, in the first 1 second over what you exhaled out altogether, times 100%. Again, normal is 80 to 100%. Normal for all the PFT values are 80 to 100%. Okay? But for this one here, the minimum acceptable is 70%. We can go all the way down to 70%. This is the only one that you can go down to 70%. If this number is less than 70%, you are obstructive, period. Look, you don't even have to worry about looking at anything else. Don't worry about looking at the FRC or RV or whatever. This is the best. Okay. The only time that you have to look at other things when you have looked at this is when you are trying to find out which type of obstructive disease that you get. That's all. Okay? If the number is greater than 70%, then you are restrictive, or maybe you have normal pulmonary function test. Okay? So that's why I tell my students, interpretation, look and see whether you are given the FEV1 ratio. Because if they give it to you, then you look and see whether it's below 70%. If it's less than 70%, then you are obstructive, period. And then you may want to look at other things to classify. For instance, emphysema is obstructive. Chronic bronchitis is obstructive. So now if I look at this, I know that it's obstructive, but I've got 2 obstructive diseases. Well, which one is it? Then that's when I would probably look at my DLCO. Okay? All right. So the one I just went on, this is flow here. Okay? That's flow. I want you to understand. This is flow. Average flow, if you want to call it that. And it is the best flow. Okay? It's better than the FEV1. It is the best indicator of obstructive disease. The best. Okay? FEF 2575. Now, what this here means is that when you're blowing out your air, you take a deep breath and you start blowing it out, halfway into doing that, what is your flow rate? So you go, and then you start blowing out halfway into your vital capacity maneuver. What is the speed of the flow coming out from your lungs? Okay? So that's what we mean. The average flow during the midpoint of FBC. Now, this flow rate here is decreasing early stages of obstructive disease. Okay? Decreased values are associated with small airway obstruction. Now, if you have, like, let's say that you have a tumor or anything going on inside your lungs, you have emphysema developing or chronic bronchitis, before you notice it, before even you start having symptoms, this number here will change. If you did PFT, it will change. Okay, so it's for early airway disease, small airways. Okay? Most sensitive, maybe reducing smokers here, maybe removing smoking causes obstruction. Seasonal allergies. Okay, normal value is 6 liters per second or 360 liters per minute. Okay. Small airway diseases. That's what this is for. And then we have another flow. FEF was expiratory flow 200, 1200. Basically, what this here means is that when you're doing your forced vital capacity, when you start exhaling out, and you have already exhaled out between 200 and 1200 milliliters, what is the flow rate coming out from your lung? What is the speed of the flow at that point? Okay? It is decreased value are associated with large airway obstruction. If you have large airway obstruction, this value here will be decreased. Okay? Normal is 8 liters per second. 8 liters per second. Any questions about the difference between 200, 1200, and 25, 75? 25 is the speed of flow at midpoint of the vital capacity maneuver. The 200, 1200 is the speed of flow coming out from your lungs after you have already exhaled out between 200 to 1200 milliliter of volume. Now let's review here. What is the difference between slow and forced vital capacity? Well, slow vital capacity is when you take a deep breath and then you exhale it out gradually but completely. Forced vital capacity is when you take a deep breath, but then you're blasting the air out of your lungs as rapidly and forcefully as possible. Both of them should have equal value if you don't have anything wrong with your lungs. If you do it slowly, you get 4.5. If you do it forcefully, you get 4.5, as long as your lung function is good. But if your forced vital capacity is less than your slow vital capacity, then you have obstruction. Okay, that will be the only time the values will not be the same. What, at what percentage will subsequent attempts of PFT values coming to be considered acceptable? 5%. 5%. What is FEV1 and what is the normal value? Well, FEV1 is the amount of volume that you exhale out in the first 1 second of your vital capacity maneuver. Normal is 80% to 100% of the predicted value. We're always going to compare what you blew out to what the machine said that you could do. 80%. If you can do 80% of that, we're good. What is FEV1 over FVC, and what is the minimum acceptable value? Well, that is FEV1 ratio. That's one name that they may call it. Well, it is the ratio of what you blew out in the first 1 second divided by what you blew out altogether. Normal, again, is 80 to 100%, but the minimum acceptable is 70%. That's why we draw the line, 70%. If that value is less than 70%, you are obstructive, period. Don't even worry about looking at anything else, unless you want to differentiate between the obstructive diseases. If the value is greater than 70%, then you are restrictive, or maybe you have normal pulmonary functional results. Okay. Now, in PFT, you can have obstructive pattern, you can have restrictive pattern, you can have mixed pattern, or you have normal PFT value. So 4 things are possible there. Which PFT value is the best indicator of obstructive disease? FEV1 ratio. FEV1 ratio. It never lies, no matter who you are. Whether you're restrictive or obstructive, that number never lies. Okay? All right, let's move on here. And then we'll go to flow volume loop. Okay? Now, I'm pretty sure that Mrs. Kati went over graphics with you. Anytime you plot, I think it's like volume, flow, and pressure. Anytime you plot a graph of any of these variables here against time, it's called waveform. Or sometimes we call it scalar. So the scalar or waveform is a graph of any of these 3 variables against time. But when you plot the graph of any of these 2 variables, okay, we'll call it a loop. For instance, volume against flow will be the flow volume loop. And then we have another loop. We have the compliance curve. Okay, so that will be pressure against volume. Or maybe let's call it volume against pressure. That's better that way, because compliance is volume divided by pressure. And pressure, volume against pressure is the compliance curve. If you look at the mechanical ventilator screen, that's the one that kind of looks like that, a football. Okay? And the flow volume loop looks like that. Okay? So a loop is nothing but a graph of any 2 of those variables together. A scalar or waveform is when any of the variables is plotted against time. Okay? We have mechanical ventilation coming in your 5th semester. We're going to review that some more. Okay? So now this is computer generated. Okay? Whether you're doing PFT or the patient is on the ventilator, the computer just draws that. Okay? It is easier to see cough and obstructions and to determine flow rate. So that's one thing with flow volume loop. Any kind of weird airway problem that you've never heard about or you don't know what it is, it will always show up on the flow volume loop. Okay, so on the exam, when they tell you that a patient has a pulmonary problem that nobody knows what it is, they can't determine through other tests, the best thing to do will be the flow volume loop. Okay, it's very good at detecting everything. Any questions about that? Okay, so now let's go there. So interpretation of flow volume loop. Now you're going to find out, I have a picture coming next, that the volume is on the vertical axis, and the flow is on the horizontal. No, excuse me, I'll take it back. The volume is on the horizontal axis. The flow is on the vertical axis. Okay. Now, so let's go here. So that's what it looks like. Okay. Just kind of draws it like this. This is not well drawn. If you look at the ventilator, you can tell that it's better than this here. But then, and then another thing I want to tell you is that on the ventilator, okay, the peak expiratory flow, this part will be up here and this will be down here. On the PFT machine, then it's like this. Okay, so it's kind of like it's switched around if you're looking at the ventilator screen or maybe you're doing the PFT. Okay, but either way you're going to know. Okay? So now, the highest point on that graph is peak expiratory flow. Okay? So that's when you take a deep breath and then you blow all the way out. How much flow that you can get out is measured on top. Okay, it will be upside down on the PFT machine. Okay? And then the lowest point here is the peak inspiratory flow. Peak inspiratory flow. Okay? So now, one thing that they may do on the board exam is they may put an arrow up here and say, you know, what is this here? Okay, so you're going to pick peak expiratory flow. Okay, the highest point in the curve. Now, here's your vital capacity, which is volume. It's measured horizontally, like that. So my volume is out here. If I draw a line here, down, I get my volume. So that's my volume. And this is my flow that way. Okay? Now, how can we use that to tell who is a COPD patient and who is a restrictive disease patient? Well, I know that in obstruction, the flow should be decreased. In restriction, the volume should be decreased. So if I'm looking at this now, here is what is supposed to be normal here with the dots. This is what the patient actually did. Now I see the flow is vertical here. It's lower than what it's supposed to be, but the volume is high here. So in a COPD patient, remember they have good lung compliance, okay? But they always have low flow. So that would be the one for COPD patient because the flow is decreased. Now look at restriction here. There's nothing, when you have a restricted disease, your airway is patent, nothing blocking your airway. So you should be able to exhale out all the volume here. But now look at your amount of volume that, excuse me, all your flow will be good. Look at the volume here. The volume is smaller compared to that. So you have decreased volume for restriction, normal flow, decreased flow for obstruction, normal volume. Okay? Okay, so on the exam, when they show me this, what do you think about? What's going on here? Okay, sometimes they may so say COPD. Well, that's a good answer because COPD is an obstructive disease. So they should look this way. Or maybe they can say increased airway resistance. That's also a good answer. Because when you have a COPD or obstructive disease, you're going to have increased airway resistance. Any questions about that? Now, the board exam is very tricky. We want to get into that in your fifth semester. They're very tricky. I mean, the people that make out the test are psychologists. Sometimes I wonder when their children go to school. No, I'm just kidding. So we can catch them. They're tricky, okay? All right, any questions about that? Now, this one here shows extrathoracic obstruction outside the lungs. That's what we call it, outside the lung, extrathoracic obstruction. See the sawtooth appearance? It's like sleep apnea. Sleep apnea is up here. It's not inside your lungs. Mediastinal tumor, okay? Not inside the lungs. So that's the way it's going to look. They show you something like that. That's obstruction outside the lungs, extrathoracic obstruction. Some more example here. This is what is supposed to be normal. Yeah. That's obstruction. See how it's pushed in here. Now, what causes this is air travel. And we call that here, what they call it is, the flow volume loop has scroll back pattern. Talking about this screw back pattern. What causes that is resistance as the flow is coming out from the patient's lungs. So you recognize that anytime you see one that looks like that, that's obstruction. That's increased airway resistance. That's COPD. That's bronchiectasis. That's cystic fibrosis. Okay? Now look at restriction here. They have normal flow, but there's nothing blocking their airway. But their volume is very small. They're very restrictive. And now this is large airway obstruction, extrathoracic obstruction. Okay? Now, peak flow. You all know what the peak flow meter looks like. Normally, we'll give it to patients that have asthma to monitor their breathing. Okay? Because now, if you don't have enough flow coming out from your airways, then that means that your airways are closing up. That's bronchospasm. Okay? So anytime a patient with asthma comes to the ER, and then you give them a breathing treatment, get them doing okay, you should always send them home with peak flow meter to monitor their breathing. Every once in a while, they blow into it, or when they start having problem, they will take a deep breath and blast it into the peak flow meter. If it goes to the green zone, it has a green zone, yellow zone, and then red zone. If they blast the thing goes up to the green zone, they're fine. If it goes to the yellow zone, well, it's time to take their bronchodilator, but their airways are beginning to close up. Well, if it's in the red zone, they better be going to the doctor, but their airways may be completely closed up. So that's what we use the peak flow meter. We're gonna blast, take a deep breath, blast it in there, and then we'll measure and see how much blood that we get. So, but we can use that for pre and post bronchodilator therapy as well. Okay? They come in, we'll put them on the machine, and we say, okay, take a deep breath and blast it in there, and then they got like 4 liters. And then we'll give them a bronchodilator. That is called the pre-test. We'll give them bronchodilator, and then we wait for a while. And then we tell them again to take a deep breath and blast it in there. And now they get like 7 liters or 8 liters. So that means that the bronchodilator that you give to them have their flow to improve. It opened up their airway. Because if their airways open up, they should be exhaling out more air. So that's what we're testing there. Okay? All right. It is effort dependent. Okay? Another thing is that when a patient is doing this and they cough, if the patient coughs, that messes the result. Because you remember, cough is explosion of air through a closed airway. Explosion of air through a closed airway. It's a lot of force. So that force of cough can cause the thing to go to the green zone, so that will be false result. So if the patient coughs while doing this, they need to do it over. Okay? Normal is 10 liters per minute, per second, or 600 liters per minute. I think we should be able to finish by 30. Because I know you've seen all of this before. Okay, so another PFT test is what we call the maximum voluntary ventilation. Maximum voluntary ventilation. This one here is used to measure the wait a minute. It's used to measure the reserve, ventilatory reserve. Okay? Ventilatory reserve. Or maybe air traffic. So actually what we do is we put the patient in the machine and we have them take a deep breath in and out for maybe 12 seconds to 15 seconds. They go for 12 seconds. And then if you want them to go for 12 seconds, then at 12-second mark, you stop them. And then you're going to multiply whatever volume, that average volume that they're getting, you multiply by 5, because 5 times 12 is 60. Okay, so 1 minute test. But sometimes we don't let them go the entire minute, because they may give up. So they do it for 12 seconds, we stop them, we take the average volume, we multiply by 5. That will give us estimate of what they would have done in 1 minute. If you have them do it for 15 seconds, then you start them at 15 seconds, and then you take the average volume, you multiply it by 4, because 15 times 4 is 60. And then that will give you an estimate of what they would have done in 1 minute. Okay? Now, if you get COPD, shortness of breath, do you think you can do this for a while? How long are you going to go doing that? So it is always decreasing COPD. Okay, it may be normal or decreasing restricted. Okay? But definitely decreasing COPD patient. This is what is the normal range. 170 liters per minute. So if we take that average volume at the 12-second mark or 15-second mark, we'll multiply them, we should get a number close to 170 liters per minute. Now, on the MDRC test, they may tell you to calculate a patient's MVV value. Okay? Now, if the FEV1 is given to you, you can estimate that. You take your FEV1 from that test, you multiply by 40. And that will give you your MVV. Remember that. Okay, the patient, pulmonary function test down, here's your vital capacity, here's your FEV1. What is the normal range or what is the patient's MVV? So you get your FEV1, you multiply by 40, and then that will be the patient's MVV. Any questions about that? Dormitory resolve is what you're looking for as an answer on the test. That's what they will say.
And I'm sorry, you're
Which
saying,
of the following will be used to measure dormitory resolve or respiratory resolve?
are you saying resolve or reserve?
Resolve.
Resolve.
Sorry. Is that Nigerian thing?
Thank you.
Right, Ashley? Yeah, I love my accent, you know? But then you can go to Britain. And you don't have to pay anything to fly the flight. Then you'll say, oh my God. Now, what I speak is British English. If you don't know now, you know. But I've been learning American English since I came here, 1980. I think I'm getting better. You know? And I can understand it, but it's just like when they mix it up. You know, go back, man. What's up, man? I got what you got. Excuse me. All right. So any questions about this? All right. Now, here's the test. That's what it looks like. You know? I'm going very fast. Kussmaul. They're almost like Kussmaul protein. Okay, now, let's go to fully imposed bronchodilator therapy. Okay. Basically, what we do is, I think I explained that before, they go to the lab. They are trying to find out if Abiro can help this patient. Okay, that's what we're trying to do. Do they need a breathing treatment? Can breathing treatment help this patient? That's what we're doing this. Okay, so they come to the lab. Before they come to the lab, you will instruct the patient not to take their breathing treatment before they come to the lab. Because if they took their breathing treatment before arriving to the lab, that would mess up the test. Their airway will begin to open up. So you won't get the correct or the accurate flow rate. Well, we tell them a day before, don't take your breathing treatment in the morning if you're going to come in the morning. Okay? And then they come to the lab, we'll put them to, on the spirometer, we say, okay, now take a deep breath and blow it inside the spirometer as fast as you can. And they do that, and then we'll write the number down. Okay? Let's say 4 liters. And then we're going to give them a breathing treatment with a small volume nebulizer, or MDI, okay, with a bronchodilator. Now, the preferred bronchodilator is Abiro. Remember that on the test. The preferred bronchodilator is Abiro, 190 kg. That's what most pulmonary function labs use. But you can use anything else, but that's just the best. So now, after we have given them the breathing treatment, now we give the medication time to work. We're going to let the patients there for 10 to 15 minutes. By then, the drug would have bronchodilated their airway if you was going to do that. And then we'll put them on the spirometer again. I say, okay, take a deep breath and blast it out into the device. And then we'll do that, and then we'll write the number down. Okay? Like I said, now you can use another medication if you want to, but Abiro is the best. Now, parasympatomatic agent will be like Atrovent. Atrovent is anti-cholinergic agent. Okay? It is to prevent the onset of bronchoconstriction But albuterol is for acute bronchospasm. If somebody's wheezing right now, and you want to take care of the wheezing right now, you give them albuterol or Zopiness. But that's not true with Atrovent. Atrovent is not for acute bronchospasm. Atrovent is to prevent the wheezing from coming back. So when you mix up your albuterol and your Atrovent to give to your patient, the albuterol in the mixture is taking care of the wheezing right now. And then the Atrovent will prevent future onset of wheezing by preventing the constriction of the airway. So albuterol, usually they call albuterol the front door bronchodilator. And the Atrovent, they call it the back door bronchodilator. All right? All right, so what we are monitoring is flow rate when we're doing this, because we're testing to see how much flow now will be coming out from the patient's lungs now that their airways are dilated by the bronchodilator. So we're measuring flow. We're looking for improvement in flow. And the way we're going to calculate that is by this formula. We're going to take the number that the patient got when they blew into the spirometer after they had the bronchodilator, which is the post-test. We take away the number that they got before they got the bronchodilator, which is the pre-test. And then we divide by the pre-test. Okay, now let me work this out. Let's say that the patient got 7 liters after they got the bronchodilator. That's my post result. And before that, before they got the bronchodilator, they only got 2. And then divided by 2. So what I got is 5 divided by 2, that will give me 2.5 times 100%. If you work it out, and the number is 12% or higher, that will be good. It means that the it means that the result is significant. That's one way that they can say that. It means that the patient can use a bronchodilator. They will benefit from the administration of bronchodilator. And there's another time that they use response, yeah. They had good response from the test, from the bronchodilator. Okay? It is significant test. 12% or higher will be good. Plus minus 3 divided by 3. 12% or higher, significant bronchodilator response. Okay? Now, reversible, thank you. Reversible is another thing. Now, when we say reversible, what we're saying is that it's not that you're curing the disease. You do not cure obstructive disease. You can cure it. But we can treat it so that you may live with it the rest of your life. Okay? You don't cure it. So reversible doesn't mean that the asthma will go away or the emphysema will go away. No. What it means is that the bronchodilator will help this patient out. That's what it means. Okay? So on the test, when they give you this and they say, well, the response is 14% or 20%, what would you recommend? You recommend the breathing treatment because that's helping them. How about if you didn't have any response? Because you can give them albuterol and have them blow back into the device and there's no change in flow. It's less than 4% change in flow. What does that mean? It could mean that the airways are not affected by the type or dose of the medication. Well, normal dose of albuterol is 2.5 milligram, okay, or maybe 0.5 milliliter by volume. If the technician only gave 1.25 milligrams because they want to save the hospital some money, well, you're not going to get good result either. Maybe that happened. That's why the patient didn't get up to 12%. Poor inspiratory effort and deposition of the bronchi. That is true. Do you know why when we give a breathing treatment, we tell a patient take a slow deep breath and you hold it and then you breathe out? That's respiratory therapy. Almost everything that you do in respiratory therapy, breath holding is very important because breath holding allows the pressure inside the lungs to equilibrate. Open up all the small lung units. If you're doing sinus parameter, breathe in, hold it. If you're doing a breathing treatment, breathe in, hold it. If you're doing IPPB, the same thing. If you're on the ventilator, we can institute pause. Okay? So breath holding is very good. So the same thing here. If you don't do slow inspiratory and then holding it, the medication will not deposit in the lower airway. Therefore, you don't get any results. Now, no response does not mean that the patient cannot have a bronchodilator. Okay? Let's say now you have somebody who has end-stage emphysema. They arrived at the PFT lab, but they don't have significant bronchodilator response. And then you go, well, excuse me, sir, I'm going to take that medication from you. You don't need a breathing treatment anymore. And before they get home, they may die on you. So it doesn't always mean that, okay? Any questions? Specialized test. Let me go ahead and finish up, okay? Specialized test, we can check airway resistance, lung compliance, okay? Airway resistance is increased in all the obstructive diseases. Airway resistance is normal in all the restrictive diseases. Lung compliance is decreased in restrictive diseases. Lung compliance is normal or increased in obstructive diseases. Okay? So sometimes you can tell. Now, if you give me PFT result and then you're at airway resistance, what's normal airway resistance? 0.6 to 2.4. That's what it is for normal person. And then you tell me airway resistance is 18. I'm like, oh, okay, they have obstruction because that's very high. It's only 0.6 to 2.4 liters per minute. No, the unit is not right. Hold on. Centimeter of water. Per liter per minute. Yeah, that's what it is. Okay? Yeah, I can tell. If you say airway resistance is 18, I'm okay, they have obstruction. Because resistance is increased in obstructive disease. And now you say, well, compliance, what's normal compliance? Normal compliance is usually 100 to 170 milliliter per centimeter of water. Okay? That's normal lung compliance for normal people. Now, you give me a compliance of 40, I'm like, oh no, their lungs are very stiff. So there has to be restriction. Or you give me a compliance of 190. I'm like, well, you know, their compliance is high because they can get 1.0. So that has to be COPD. Okay? Sleep study. Okay, well, they usually don't do sleep study inside the PFP lab, but the patient can be recommended to go and have sleep study done. Okay? They don't breathe well, it can be sleep apnea. Okay, maybe it's nothing down here. Okay? So we have obstructive sleep apnea and central sleep apnea. You know about that, right? Obstructive sleep apnea is when you have a lot of airway structures that are blocking your airway when you sleep. Because usually what happens is that when you go to sleep, the tissues and the muscles up here lose their tone. They become very floppy. So if you got a lot of it, they will collapse. You can block inspiratory flow. So the patient will start snoring because of the obstruction. That's when they're going to need CPAP, right? That's the most common treatment. But now central apnea is different. It's not obstruction. Central apnea is neurologic in origin. Okay? The brain fails to signal the diaphragm to contract. It's neurological. And then you don't breathe. Okay? So that's what they're going to find out from the sleep lab if you have. And then this one here, we talked about it, neurological assessment. The central nervous system is able to detect carbon dioxide. Okay, because by the way, that's the way we breathe. Anytime, what's normal CO2? Anybody?
40.
Yeah, 40, thank you. What's acceptable CO2?
35.
To 45. Okay, now, please, you gotta know what is acceptable and what is normal, because on the exam, like I said, what's normal CO2? I go, well, it's 35. No, it's not 35. It's 40 in the middle. But they say, well, what's acceptable CO2 is anything between 35 to 45, but not 40. Okay? Now, what's normal pH?
7.35 to 7.45, or normal?
Okay, now you
normal
get that.
7.4.
It's 7.40.
Yeah.
What's normal bicarb?
24.
Huh?
24.
24. What's acceptable bicarb? 22 to 26, but not 24. Okay? So you learn that, because they do ask that on the exam. Okay? All right, so what we're going to do here is, in order to test and see that the central nervous system is working well, we're going to let them breathe in some CO2. CO2. CO2 diffuses faster than oxygen. You go ahead and diffuse inside the lungs and bind with the hemoglobin and prevent oxygen from binding to it. Therefore, your oxygen carrying capacity will go down. You become hypoxic. When you become hypoxic, what happens to your heart rate? It goes up. So if that happens, we know that your CNS is working very well. So that's the neurological assessment. Okay? And then the last one here is called the bronchial challenge or provocation test. You want to provoke somebody. Okay? You know what provocation means? Just like Russia now is trying to provoke the United States. You see that on the television? We're trying to attack Ukraine. Okay? All right, so what we're doing here is that we are intentionally going to induce bronchoconstriction. We make the airways close up. Okay? And then we see how much flow or how much decrease in the flow because of the airway closing up. that's how we make diagnosis of asthma. If you think somebody has asthma, they come in, we're gonna give them something to breathe in, to close their airway up and see if the flow coming out from their lungs now will decrease. If it does that, then they may have asthma or reactive airway disease. That's why we're doing this, okay? So this is used to detect subclinical asthma or airway hyperreactivity. You gotta have to sign a consent form. Because if you give somebody something to breathe in and then they die at the spot, you are responsible. They're not gonna let you go just because you're the respiratory therapist. So you have to tell a consent form is a form that the patient signs agreeing to the therapy and the complications that may result from the therapy. So they have to sign it. And then what do we have the patient inhale? We can have them inhale methacholine. That's a drug. So this test also is called methacholine challenge test. Methacholine is cholinergic. A cholinergic agent will cause bronchoconstriction. It will close up your airway. So we can have the patient inhale some of that. If we don't want to use methacholine, we can use histamine. Histamine can also close your airway off. We can use cold air. People that have asthma, usually they have exacerbation when they come out in the cold weather. They breathe in that cold air, they have problems. So we can give them a little cold air to breathe in. And then we can have them to exercise. We have exercise-induced asthma as well. When people have asthma, they exercise a little bit, they have exacerbation. So now, once we do any of that, whether that's inhaling methacholine or histamine or cold air or exercising or whatever, then we measure the flow, okay? The flow should already be measured before they start doing this, okay? They come in, we have them blast into the device, we measure their FEV1, or maybe any of the flows, FEV1, or maybe the FEV1 over FVC, or maybe the 25, 75, whatever, any kind of flow. But mainly they use the FEV1 for this, okay? So, what we're looking for is 20% decrease in flow. If there's a 20% decrease in flow from what they got before, you expose them to any of these, what would I call them, triggers, okay? Then they have asthma or reactive airway disease. Any questions about that? Okay? Now, this is the way that we classify the diseases, the severity of the diseases. Because it can be normal, it can be mild, it can be moderate, it can be severe. You can have severe emphysema, you can have moderate obstructive disease or moderate restrictive disease. This scale, now if you look at it, it looks familiar. That's the same scale that we use for blood gases, right? 8200 normal, 60 to 79 mild, 40 to 59 moderate, and less than 40 severe. If I want to classify obstructive pattern, whether it's moderate or severe or whatever, I look at my FEV1 or the FEV1 over FVC flow, because I'm measuring flow for obstruction. That's what I'm measuring, so that's why I'm going to use flow. If both of them are given, then you use your ratio. Your ratio is the best flow. If both of them are given, and then you want to classify the degree of obstruction, then you use your FEV1 ratio. Any questions about that? for restriction, okay, you're going to use your vital capacity, because restriction means volume. You're not getting enough volume in. Okay? If my vital capacity is between 60 to 79% of predicted, that would be mild restriction. If it is 40 to 59 of predicted, then that would be moderate restriction. Okay? If it's less than 40, then that would be severe restriction. The same thing with obstruction. If my flow is 60 to 79, that would be mild obstruction. 40 to 59, that's moderate obstruction. And then less than 40 is severe obstruction. And again, let's touch on the ratio again, the FEV1 ratio. It is the best value out there. Whether you're restrictive or obstructive, it never lies. It will tell you who the patient is. So again, the minimum acceptable is 70%. Normal is 80 to 100, but the minimum acceptable is 70%. If that number at any given time is less than 70%, you are obstructive. Don't even worry about anything else. Don't worry about that, unless you're trying to classify or differentiate between the obstructive diseases. If it is greater than 70%, then you are restrictive, or maybe you have normal pulmonary function results. So this is what they call gold standard. You know, I haven't seen this a lot on the board exam, but it's out there. You know, like when they come here to teach you to take the test, they will teach you there. They sometimes want you to classify the COPD. COPD, okay? COPD. Now, two diseases that we call COPD. Chronic emphysema and, emphysema and chronic bronchitis. Okay, so this is where we're going to classify the COPD. You have FEV1 over FVC less than 70% in all of them. That's where I remember it. All of them, it will be less than 70%. But if your FEV1 is 50% to 79% of predicted, then you have moderate COPD. Moderate COPD. And then the patient will be having shortness of breath on exhaustion. If your FEV1 over FVC again is less than 70%, but your FEV1 is 30% to 49% of predicted, then you have severe COPD. And that means that the patient will have shortness of breath, will worsen, and limits patient daily activities. They're not able to do things that they would normally do. And then if your FEV1 over FVC is less than 70%, but your FEV1 is less than 30%, or FEV1 less than 50 are predicted, then you have very severe COPD. This is just to classify the degree of COPD, which is chronic bronchitis or emphysema. Any questions about that? Now let's review here. What drug is best to use for pre and post bronchodilator therapy? Albuterol. Now it doesn't mean that you can't use any other type of drug like Atrovent. If you're using the Atrovent, which is anticholinergic, you gotta wait longer for it to take out effect. Okay. What percentage decrease in flow rate during bronchial challenge tests or metacolon challenge tests confirms the presence of subclinical asthma? 20%. If there's a 20% decrease in flow after you let the patient inhale that metacolon or histamine or codeine, then the patient may have asthma or reactive airway disease. What is the meaning of significant bronchodilator response, and what percentage is significant? 12% or higher is significant. What does that mean? It means that the patient can benefit from the use of bronchodilator. Okay, that's what it means. Okay. Now, if they use the word reversible, well, it still means that the same thing. It doesn't mean that you're going to cure the disease. It means that the breathing treatment is going to help them out. What is flow decrease in obstructive disease? Well, flows will be decreasing obstructive disease because of obstruction in their airway. 5 of them, 5 obstructive diseases, each one of them has a way that it limits expiratory flow. Now let me go through them one more time. 60 fibrosis, a lot of secretions in the airway. The air can come out. Chronic asthma, bronchospasms. The diameter of the airway will narrow. Air can come out. Bronchiectasis, where you have things breaking and rupturing, air comes out and then it comes to where it's broken, it diverges and comes out to the lungs instead of following the pipe out. You talk about emphysema, you have loss of elastance. Their airway will not rebound because they've lost a lot of fibers due to the cigarette smoking. And then you come to, which one am I missing? So I talked about CBER, so I talked about cystic fibrosis, bronchiectasis, chronic asthma, emphysema. Which one am I missing?
Bronchitis.
Huh?
Bronchitis.
Okay, bronchitis, thank you, chronic bronchitis. That's secretions too, okay? All right. What is it now? Why is flow decrease? No, I think I went through that. Why is volume decrease in the restrictive disease? Because of low compliance. Their lungs cannot expand. Therefore, it cannot get enough volume. Any more questions about this? All right then, so we're done for today. I will see you on Tuesday, okay?
When is our next, or when is test 1?